And patient safety is maybe just slightly different than kind of the theme that we've been going on because it is a very quick clinical encounter that we're trying to activate the patients to become involved during. So many patients, as Carolyn said this morning, are quite shocked that they're not safe to begin with. So starting that conversation about patient safety can actually be quite difficult when that understanding of risks and awareness of adverse events isn't always a given. So you know a little bit about who I am, and I think we all know kind of why I'm here today and preaching to the choir, obviously, with this particular audience. But really, a lot of the impetus for my research was looking to research that was being conducted in the UK, better understanding the likelihood of patients to ask certain questions or to become involved in their care in certain instances, and the realization that patients can be quite hesitant to engage in certain patient safety practices. And these are usually delineated between factual patient safety practices, which is aimed at educating myself about my illness, and then those really kind of sticky, challenging patient safety practices, so that ever elusive asking of your healthcare provider has actually washed their hands, how many times they've actually done a treatment or procedure. So connecting the dots for me was very interesting because a lot of this research that was starting to come out about patient engagement and patient safety was really asking that likelihood. But there wasn't really a lot of research to support how that kind of coincides with the provider ability to engage patients with asking those questions, so whether or not they're inviting those questions to come forth. And also what role organizational culture really plays in allowing those providers to engage patients as well. So to start off, there's a few dilemmas, and this is kind of plagiarized from Hofstede's cultural dilemmas. And what he looks at is the broader kind of global scale of those competing interests that we have. So masculine versus feminine, short versus long-term goals. And a lot of these dilemmas really do correlate with patient safety as well. So there's protection versus production. So we work in a healthcare system that really does reward efficiency and getting people out of the door. Routine versus critical. So something that's very routine for a healthcare provider, like a surgery, is actually a very momentous occasion for a patient. And how do we kind of satisfy that dilemma? There's individual versus system dilemmas, and then there's also provider needs to care for patients and patient needs to actually be cared for as well. So in an attempt to start to figure out and unravel kind of this mystery of what's really going on, my doctoral research was trying to understand patient engagement in patient safety from those three lenses, so the patient, the provider, and the organization. And in order to do this, surveys and focus groups were conducted with both patients and providers, and this also did include some administrators as well. And the aim here was to start to apply a theoretical approach to patient engagement and patient safety. As our journey since 1999 and the release of To Err is Human, patient safety has been fairly atheoretical, and that's starting to kind of build up some momentum now. So while I chose the health belief model, there's also lots of research going on with theory of planned behavior and other cognitive and social behavioral theories such as that. So health belief model is kind of an oldie, and most people would also say it's a little bit moldy as well. But I like to, I dusted it off a little bit to apply it to patient safety. And for those not familiar, the health belief model was really pioneered in the 50s and 60s, and to better understand why the public were not engaging in free tuberculosis screening clinics. And so really what it is understanding patient engagement in health protective behaviors. And so for me, that was patient safety. When we're asking people to do certain behaviors that are going to protect them from experiencing an adverse event, it's really quite analogous to the same thing as whether or not we're asking them to go get a vaccination, or if we're looking at condom use and that sort of thing that the health belief model has been applied to widely. So just to kind of not be too academese about this, there's certain constructs that we're looking for within this, and it's understanding patient perceptions of susceptibility and seriousness, threat, cues to action, which can be both internal and external, and demographics, of course. Perceived benefits versus barriers. This is often a big one anecdotally, so if I speak up, and we've heard this today, we don't want to be labeled as that difficult patient. So what is that kind of internal struggle that's going on, which will lead to a better understanding of the likelihood of actually engaging in patient safety. So I promise that there won't be a pop quiz on this. It's a bit of a gobbledygook, but it's the most beautiful model in the entire world to me. And there's three main things that I want you guys to really take from this. The first is the fact that those factual and those challenging patient safety practices are two different constructs. So when we're asking patients to engage in patient safety, there are different ways that patients conceptualize what that looks like, and the danger that's involved in actually speaking up. So more likely to become involved in factual patient safety practices aimed at educating themselves, less likely, obviously, to speak up and challenge their healthcare provider. The really awesome mediation effect of self-efficacy, and I think that that's really what everybody's been speaking to today, is the self-efficacy, is how do we grow patients to the point and build up their confidence that they can become partners in their care through all levels, at that clinical encounter as well as through health systems planning, and how much that self-efficacy actually influenced their actual participation in patient safety strategies. And then barriers versus benefits and threat being two very important perceptions that we can actually tap into when we're trying to engage patients. They sound a little scary, but the threat is really important that we engage and educate patients that healthcare, can be scary. Things do go wrong sometimes, and that's why it's really important that they become involved in their healthcare. But interestingly enough, that kind of range, that threat of having an adverse event, really ranged, honestly, from 0 to 100% within that patient survey. And honestly, that also happened with the provider survey, so it's very interesting to see that interplay. This is a little bit of a cleaner model, but this is how the provider results kind of started to conceptualize together. And here it was interesting that the factual versus the challenging was not separated for providers. Now, this could be that they're comfortable in engaging in both, or they're actually just not ever engaging in either. And so that was a little difficult to figure out. It was interesting to see, actually, that they mapped on really well together. So the patient results indicated that out of all of those patients, only 4 had actually asked if their provider had washed their hands the last time they were hospitalized. Well, only 3 providers had actually ever encouraged their patients to ask them if they had washed their hands. So those all mapped on really well. So if we're trying to get to that patient, we need to start with that provider. And of course, the really important crux of this is that safety culture component in this particular model. And that's the communication within the organization and amongst healthcare providers that patient engagement is okay, that their ideas are listened to, that they're empowered to participate in committees looking at patient safety, that they have good safety climate, so they feel that there isn't a blame and shame culture and those sorts of things, as really laying the groundwork for those patient safety practices. And so we also did some follow-up focus groups, and this was to better kind of do a deep dive into what we found in those models. And there really was a lovely kind of continuum of that experience of patients and providers, and they really were not different at all. So what patients were feeling, providers were really feeling as well. So the first major theme was that wanting control. So not feeling that you're warehoused, that you're an object, but also providers wanting to feel that they can actually take that time as well. And that really went into feeling connected. And I think we've heard that throughout today's sessions, that it's the hearts and the minds that really help to engage patients and providers in engaging patients as well. And so wanting to feel that connection, and that was the singular most important aspect of that patient experience that allowed them to speak up and become engaged in their care. Of course, we encounter roadblocks as well, and these really were very wide-ranging. A lot of them had to do with environmental structuring within the hospital, so thinking about privacy. And it was interesting to me actually how aware patients were that when they did speak up in a semi-private room, that everybody could hear about it. And so what are we doing in order to kind of address that? If we're asking patients to divulge personal information during that clinical encounter, how do we safeguard that for them as well? And then obviously a lot of the patient safety protocols that we're doing right now and required organizational practices do include some extra workload for a lot of it. So looking at checklists and that sort of thing, falls checklists, but what is that really actually doing to help to engage the patient in that conversation? Because really it's something that can be done while charting, but actually doesn't involve the patient in that encounter at all. Very encouraging, though, that patients, at least in this study, and I know that you do usually get the cream of the crop when you do a research study, but patients really seeing that they do have a role to play in their own safety. There's obviously still lots of inroads that need to be made, but patients as well as providers really understanding that it's that co-creation of safety that's the most important. So what we actually need to pay attention to is context, workload, and language. So creating that environment for interaction to occur. So being comfortable to ask those sticky questions. Modeling that behavior and having providers model that to one another. So what does that actually look like when we're inviting that conversation to occur? What does that look like when we're inviting patients to ask those questions? And patients view providers as being extremely stressed. And I was talking about this yesterday about some of this could be the maritime hospitality, but I'm sure that it has, rings true throughout Canada as far as if somebody's really in a hurry, we don't want to speak up and contribute to that busyness. And so that's a huge deterrent for patients. And that was something that came out over and over and over again. That was very interesting finding from this. And then patients are unaware and unsure of what patient safety means. So there was a little bit of a disconnect between what patients understood patient safety as. To them, it really was psychological safety, being cared for, feeling safe within that hospital environment. Whereas providers really saw it as a more traditional view of medication safety, fall safety, and that sort of thing. So being very clear about what patient safety means is very important when we start to launch patient safety campaigns. So some of the research that I've been doing lately that is built upon my doctoral research has been looking at that role of safety culture. And yes, as we've been talking about, that patients can tell us how terrible the food tastes, but we don't necessarily always give them the opportunity to tell us about how we're actually doing. But really, they're a captive audience. They're in a hospital bed, they're seeing the hustle and bustle around them, and they can give voice to actually what's going on. So this was one small little study we did. Being a postdoc, money flow is always an issue, so these are publicly available patient and family stories and narratives on the CPSI website. And better understanding those stories of experiencing harm and what they actually told us about patient safety culture. So 4 themes were identified: not being heard, betrayal of trust, missed opportunities, and being passed around. We also underwent a Nova Scotia patient experience survey last year, and that was better understanding once again what they can tell us about safety culture. Traditionally, we look to staff perceptions of safety climate, so there's lots of surveys available for use for that, safety attitudes questionnaire, but we actually don't necessarily take into account what the patient experience of that safety culture is as well. So I just want to, I know I need to be brief, probably give highlight to that first one right there, with the negative experience with providers had a 5-time increase likelihood of experiencing an adverse event while hospitalized. So that really speaks to what that culture looks like and how that clinical encounter really does shape the patient experience and also the likelihood of having a safety incident. So what does this mean for connecting the dots? There's certain perceptions that we can use to improve involvement. So we can tap into threat, self-efficacy, and benefits versus barriers, and we can do that through a number of means, including social marketing and interpersonal communication. Patients are highly perceptive of healthcare provider behavior. Once I said, they're the captive audience sitting in that bed often and seeing what's going on around them. And we need to tap into that resource a bit more to better understand what our safety culture looks like. Yeah. Thank you.